So, first of all, thank you for this fine presentation on vestibulopathia bilateral. I liked it very much. Now we talk about another frequent disease. It's Enfermedad de Ménière. And I always love to go to the history, because many things which we think are new have already discovered 100 years ago. So the disease by itself has always been present. You just describe it or classify it, but there's nothing basically new. And the same is also true for the physiology. So most of the things we know about the physiology of the vestibular system were already described in 1870 by famous physiologists who did animal experiments, who had a lot of time for thinking, and who were not distracted by 100 emails a day and the internet. So they were just more focused, and we are not brighter today than they were 100 or 200 years ago. So we should be very modest and humble. Good. Here is a little overview of the milestones of the history of Enfermedad de Ménière. So first description, we can precisely date January the 8th, 1861. I go into the details, show you the original papers. Then already in 1872, this famous French neurologist, Charcot, recommended neurectomy for Ménière's disease. However, in those days, many people died after neurectomy, so this happened later too. Then 1926, George Portman from the US recommended endolymphatic sac decompression. Nothing new. Then 1936, the otolithic catastrophe. 38, endolymphatic eye drops. And a hot topic in many conferences is nowadays the association between migraña vestibular and Enfermedad de Ménière, but this is not new. So this is known for 56 years or so. So we should not recook everything. The second time it's not better. Pathophysiology of attacks, already described precisely in 1984. We had an ongoing discussion about endolymphatic eye drops and Ménière's disease. But this discussion, and I'll show you all the details later, already happened in 1989. Not on the basis of an MRI, but on the basis of histopathological studies. And finally, in 2015, we have the current classification. So, this is very difficult to read. That's a pity, because here you could also see the details of the description. La Marseillaise. Any French people who stand up? Levez-vous, s'il vous plaît? Oh, okay. Good. So that's a contribution to these great French, mainly neurologists. And neurology was so strong in those days that the symptoms of Ménière's disease were attributed to epilepsy. So neurologists thought everything comes from the brain. And the contribution of Monsieur Prosper Ménière was that he examined the whole body of a 19-year-old patient who had recurrent attacks of vertigo, and he found changes in the ear. And that was his contribution. Before that, it was here, la congestion cérébrale apoplectiforme. Yeah? Well, patients can also have a transient ischemic attack with similar symptoms, but the majority has an inner ear problem. So this is what he described. And 1874, Jean-Martin Charcot called it Maladie de Ménière. So he named it after him, which was very generous. And for those who would like to go into the details and speak a little bit French, you take a photograph and here's the whole histoire de Enfermedad de Ménière. Okay. Another thing is the spelling. Well, we have to be precise in our thinking and our language, and there's a huge confusion which we can easily solve. The original source, as your patient, is the way Prosper Ménière signed his documents. And he used only one accent grave, as you can see here, only one. But in those days, it was very popular to have a lot of accents. And his son, Émile Antoine Ménière, simply added here an accent aigu to the E. And that caused the confusion. And the confusion is even worse because on the tombstone of the family, it was also written that way, Ménière, with 2 accents. But for you, from now on, the only correct spelling is with 1 accent grave on the second E, Prosper Ménière. Good. Here you see the CEO of BMW. So that was his first presentation. It's on YouTube, so I'm allowed to show it. By the way, he was my patient in addition, but this is something I can tell only people here in Latin America, not in Europe. So he had this abrupt fall. What do we diagnose? What do we diagnose? Vestibular drop attack. Oh, that's a pity that you cannot read that. I don't know why the projection is so bad. Anyway, so the first description of this was not by Toumarquin, but here by some French doctors who described that before. So he was not the first, but Toumarquin mentioned that in his paper in the British Medical Journal in 1936 already, that he was not the first one. But again, his contribution was to assign it to the otolith. That was his contribution, and therefore we call it Toumarquin's otolithic catastrophe and not crisis. I don't know who used the term crisis, but catastrophe is even better, and it's the original term. And here, he described it in a very nice way. It's like a suit which falls without a body inside. That's the way patients can fall. What he also realized is that it's related to the sacculus and the utricle, depending on the symptoms the patients have. Mainly it's a sacculus problem, and the vestibulospinal reflex is lost. And this occurs if the endolymphatic hydrops is so large that it already reaches the saccule. So most often it's in the course of the disease after a few years, then you have these. Rarely it can also happen in the beginning. Most patients do not lose consciousness. I say most, but in some patients it's so severe that it's like a syncope, and then it's difficult to make the diagnosis. So all patients need a complete cardiovascular workup. So as a neurologist, I always say no heart, no brain. So a syncope from the heart is much more serious when it comes to survival than a syncope from the inner ear. So complete diagnostic cardiologic workup, several long-term electrocardiograms, very important. But from now on you call it otolithic catastrophe. Now we move to the year 1938. Very intense times. This is Charles Skinner Hallpike. Do you know someone who's called Dix? Is it a he or she? It's a she. Okay, Dix Hallpike, it's a she. She died a few years ago, so she reached a very high age, so it's a she. Dix is she. Ruth was her name, Ruth. Dix, but Hallpike has become a little bit more famous. Here there were patients who died after neurectomy. You see, it was a serious procedure. They didn't have any attacks anymore, but that was not the primary intention. And then he just had a look at the inner ear, and in the same year, Kiyoshori Yamakawa published also a paper on endolymphatic hydrops in the inner ear. So this is a long story. But actually I would imagine that George Portman already in 1926 had an idea about endolymphatic hydrops because he recommended endolymphatic sac surgery. So again, those guys are not the first one, but they described it very precisely, and accidentally it was published in the same year here in English, and in those days German language was very popular for research, even in Japan. Good. So now we move over to another topic, which had a revival after gadolinium MRI of the inner ear, and this is the endolymphatic hydrops. And the basic question is always, do all patients with endolymphatic hydrops have Meniere's disease? And the answer is no. But this is not new, because Stephen Rauch from Boston did a double-blind temporal bone study. And he looked at patients who had Meniere's disease and patients who had no Meniere's disease. And in patients with no Meniere's disease, here in 6%, he also found endolymphatic hydrops with the same extent as patients with Meniere's disease. And this slide here is from 1989, not the slide, but this graph here, and we have nothing learned about the pathophysiology over these 30 years, because they speculate autoimmune reaction, allergic response, blocked drainage, excess endolymph, autonomic disbalances, viral infections, dietary differences, and vascular factors. Nothing new. So we have made no progress, except a little bit of genetics. And here he stated, our findings of cases meeting the histopathologic criteria for endolymphatic hydrops, but failing to demonstrate the clinical presentation of Meniere's syndrome, raises questions about the validity of this dogma. Good. Then, the year 2007, a Japanese group used high-resolution MRI of the inner ear after transtympanic injection of gadolinium, and thereby they could visualize endolymphatic hydrops. The basic mechanism behind this is that gadolinium diffuses in the paralymphatic space only, and if you have an enlargement of the endolymphatic space, you get these black dots. This was described 10 years before already in the guinea pig, but nobody used this technology to apply it to humans, which I don't understand, because it was straightforward. Anyway, but this led to a huge number of papers, 339 hits on MRI and Ménière. They all asked the same question. What is the relationship between Enfermedad, Ménière, and lymphatic hydrops? And then we have a revival also of terminology, delayed endolymphatic hydrops, Meniere's syndrome, Meniere's disease. And it's even worse, in this study we published in patients with migraña vestibular, that patients with migraña vestibular also have endolymphatic hydrops, which by the way is not worse but easy to explain. Because any disease which affects the inner ear can lead to endolymphatic hydrops. So the story is very simple. We should not oversimplify things, but we should not make them too difficult. So, in this study here, we found in 21% with migraña vestibular endolymphatic hydrops. So, putting that all together, my simplistic statement related to formal logic is as follows. Endolymphatic hydrops is a necessary, but not a sufficient conditions for Enfermedad de Ménière. And I think then we can close the case. Good, now look at this patient and try to see which direction the nystagmus is beating. The fast phase is beating to the left. Which labyrinth is more active? The left one. And our colleague comes 20 minutes later and he describes, oh, now it's beating to the right. Are they both wrong? Are they both right? What is the diagnosis? Enfermedad de Ménière in an acute attack. How can you explain that? Well, we go back to medical school. Anatomy, physiology, Hodgkin-Huxley equation and things like that. So a revival of what you have learned at medical school. Now you can apply it. So here we have a slice through the ductus cochlearis. The endolymph contains a very high concentration of potassium, so it's like intracellular fluid. Oh, it's hard to see that. What a pity. Otherwise you would see this equation here. So, 1984, Harold Schuknecht from Boston described the pathophysiology of the attacks of Ménière's disease. He's stating here that there's a neurotoxic endolymph. I think this is overstated. It's basic physiology. So what is happening? If there's a rupture of the endolymphatic membrane, the potassium-rich endolymph moves into the perilymph. And then you have an increase, you could see that here theoretically, an increase of the extracellular potassium concentration, and according to the Goldman-Hodgkin-Katz voltage equation, there's a depolarization. Oh, what a pity, you don't see the details. This is a fast sodium channel. I promised you we go back to medical school. Such a fast sodium channel has 3 states. First, it's closed and can be opened, but then there has to be a hyperpolarization that it comes into a state that it can be reopened. But if you have a slow depolarization, the voltage is not negative enough to go into a state that it can be reactivated, and that's the reason for the conduction block. So to summarize everything, you have a depolarization, you come closer to the opening of the fast sodium channel that gives hyperexcitability, then you depolarize further and you get a conduction block. Any questions on that? That's the reason why you have this change of direction of nystagmus in an acute attack of Enfermedad de Ménière. Good. And this is something which I mentioned. So patients can send you a video in an attack, and that helps you very much to make the diagnosis. So tell the patient, send me a video, and then you see the nystagmus, and if it changes direction, it supports the diagnosis. And in addition, use an app to measure hearing during an attack. They give quite good results. Okay, here are the diagnostic criteria. So that was an international team, including the Bahraini Society, the Japanese Society, and also the Korean Society. We agreed on these criteria. And it's important to note that there's no vestibular testing included. It's just an audiogramma below 2000 Hertz of at least 30 decibel, and it should be related to the attacks, which is most often neglected. And here, this is the suggestion by a consortium of the subgroups of Ménière's disease. When I saw that the first time, I found it extremely confusing and not helpful. But using this subclassification has turned out to be clinically very helpful, because we have here, for instance, one group, unilateral Ménière's disease, sporadic Ménière's disease with migraine. That's a clear entity. Or it can be associated with autoimmune diseases. So we have unilateral and bilateral Ménière's disease with these different subgroups. There's, for instance, delayed Ménière's disease. Hearing loss precedes vertigo attacks by months or years. So this is a quite helpful and precise classification, and you take a photograph, please, of it. And then you can specify your patient, whether it's unilateral or bilateral. Bilateral, you'll find in about 45% during the course of the disease. Good. Now, we have finished the history, and I'd just like to summarize some trivia on Ménière's disease. First, the prevalence. The prevalence varies very much from country to country. That means from ethnic group to ethnic group. So here in Japan it's very low. In Finland it's 15 times higher, which clearly shows that there are genetic components. Bilateral Ménière's disease, after 20 years, 45% don't give gentamicin. The spontaneous course is not too bad. That's important for randomized controlled trials. So there's a strong placebo effect of up to 70%, similar to headache. And we realized that in our clinical trial, which we published in the British Medical Journal. Vestibular testing. What is so particular with Ménière's disease? and we just organized a collaboration, Alfredo and myself, between Munich and Buenos Aires in a research project during the coffee break on this topic. So what's so special with Ménière's disease, calorics and video hit? Dissociation. So you typically have a normal head and pulse test while you have a reduced caloric irrigation. How can you explain that? Simple biophysics. Due to the endolymphatic hydrops, the inner radius of the endolymphatic duct increases, and the volume flow is proportional to the square of the diameter. This leads to a pseudo-normal head and pulse test. That's the explanation. Very simple. Okay? And this discrepancy is really very reliable, and we put our patients together on migraña vestibular et Enfermedad de Ménière and look at the predicted value of this dissociation between calorics and video hit. Okay, so now I saw 2 patients today. What counts for the patients is the treatment. Por favor.
¿En qué momento miden esa?
English, that's easier for me.
Oh. Yes. At which time of do you? That yes. The dissociation.
Yeah. Okay.
You.
So the dissociation depends on the number of attacks patients have. So if you have 1 attack, you don't properly see it. So for this study, we include only patients who had at least 10 attacks. Yeah, so in the first or 2, you probably will not see it because there's no damage to the labyrinth. But the measurement is important for rehabilitation. So you have patients with Ménière's disease with attacks only, and then you have patients who have attacks and postural imbalance and dizziness leading to vestibulopathia bilateral, and they need in addition vestibular exercises. So vestibular testing is not essential for the diagnosis, but for the consultation and the treatment of the patient. And here you see 6 measures which are not effective in Enfermedad de Ménière. So, endolymphatic sac operation, salt-free diet, caffeine-free and alcohol-free diet are not helpful. So enjoy your life with a Malbec or whatever you need. Then diuretics, Ménière device, intratympanic dexamethasone. There was a press release by the company from California, and low dosage of beta-histine. We have to face that. Although this is supported by Abbott, this is reality. You have to go up to a higher dosage. Gentamicina is effective, but it impairs vestibular and can impair cochlear function and should not be applied in patients with Enfermedad de Ménière bilateral. Yep.
I have a couple of questions. One of them is, do you know any treatment or any recommendation when you find a patient with a delayed, or you have a suspicion of delayed Ménière disease? It means you have the typical pattern, no? With the audiogram, with compromise of the lower audiogram. So the other is after Adrian work, that means that the system do not demonstrate be helpful in the disease. Do you believe?
That's not true. So that was my study. I designed it. I got the money. I'm the senior author. So I know all the details. The statement is a low dosage is not effective.
Oh, yeah,
But this was generalized in a not appropriate way, exclamation mark. So high dosage, as you will see, is extremely effective, and we already treated 1 patient with a combined therapy. And when it comes to delayed endolymphatic hydrops to delayed Ménière's disease, the treatment is not different. What counts is the number of attacks. Further questions?
Yes. We always have the experience with patients with low dose that if we keep the treatment works. But if we go down with the dose, the patients appear again the symptoms. Don't you believe it's important to consider the new classification according to different phenotypes in Ménière disease in order to define which are the healthy or not.
The question is fine, and the background is very simple. If we design a new clinical trial, we have to consider the subtypes for a clinical trial. This is the consequence. Okay. So, now listen to these patients here. Let's see how... Oh, we don't have a sound. You will not hear them. So she had all days an attack. So 48 milligrams TRD did not have an effect. We went up to 50 tablets, that means 1200 milligrams per day. And now she was free attacks for 3 months. Free of attacks for 3 months. So the motto in those days was to titrate the attacks. And this we already published in 2011 in this case series. So the higher the dosage, the higher the efficacy. Another important aspect which is often neglected is the duration of the treatment. If you have a chronic persisting disease, like diabetes or arterial hypertension, you need a long-term treatment. So we had today one patient who said, okay, you need a treatment for at least 4 years. That's the motto. Okay, here you see, more or less, maybe we'll work later on the projection, how we treat our patients. So this here goes up to 1,960 milligram. The majority is happy with a daily dosage of 288 milligram. And the aim of the treatment is free of attacks for at least 6 months. This is analogous to epilepsy. Now, the basic problem with beta-histine, and this is known for decades, it's pharmacokinetics. Because 99% is metabolized in the gastrointestinal tract by monoamine oxidases. So the oral availability is only 1%. Okay, I saw the patient last week, so he had 1 attack now in 12 months. So I was always thinking, but I was fortunately wrong, that it's not allowed to combine both treatments. But it's written that you have to inform the doctor when you take A or B together. That's all. And after I realized that, I now treat practically all of my patients with a combination of siligeline and beta-histine. That means for your country, you can give the approved dosage, or a little bit higher, which we already started today, and then you can add 5 milligrams siligeline at night, or 2.5 in the morning and 2.5 at night. So our starter dosage is now 69 TID plus 5 milligrams siligeline. And by doing so, the maximum dosage needed for the patient to become free of attacks is only 1/5 of what originally was given. And we currently run a phase 1 trial to look at the pharmacokinetics of beta-histine only and beta-histine in combination with siligeline. And based on these findings, we have the funding for a 3-arm proof of principle trial with a monotherapy and a combined therapy in Enfermedad de Ménière. And that's a good approach. And Now many doctors all over the world, India, Australia, Latin America, use a combined treatment. At the horizon, we have an intranasal delivery, which is consequent, because this bypasses the first pass effect. And then you get concentrations which are 70 times higher than 48 milligram TID. We just started a clinical trial in vestibulopatia aguda unilateral. If we have enough safety data, we will continue with Enfermedad de Ménière. But the same strategy. So, how can you explain the effects of beta-histine? We have a wonderful collaboration with our ENT colleagues. We measure by fluorescence angiography cochlear blood flow. And by doing so, we examine a wide range of beta-histine dosages per kilogram and end it up with a sigmoid dose response curve, which is convincing. If you correlate that with single dosages, you see low dosage is not effective, high dosage is clearly effective. We also had a look at the metabolites. The metabolites are effective, but the half-life time is only 2 minutes. We could identify the underlying receptor. It works as an antagonist of the H3 heteroreceptor, leading to vasodilatation. And this paper here from Scandinavia is in strong favor of what we think, what the mode of action of beta-histine is in Enfermedad de Ménière. In human inner ear, they demonstrated here in yellow-green the H3 receptor, leading to vasodilatation. But here you see the endolymphatic sac. And here in yellow-green, you see the H1 receptor. And the H1 receptor, if you activate it, increases permeability. And that's probably the real mode of action. Increasing the permeability of the endolymphatic sac and also the endolymphatic membrane, and thereby slowly decreasing the endolymphatic hydrops, or preventing an increase of pressure leading to an attack. Good. We are approaching the end of the presentation. Prophylactic treatment of Enfermedad de Ménière, at least 96 milligram TID or 48 TID at least in combination with siligelina. Not effective, many other measures which have been applied for many years. And here is the summary. Prophylactic treatment of Ménière's disease, the 4D. Diagnosis by the diagnostic criteria. Drug, beta-histina, dosage, much and long, ideally in combination with siligelina, and duration, at least 12 months. And we also have to discuss when do we treat a patient. If they have more than 2 attacks a month, then we start a prophylactic treatment, 2 per month. But this depends on the patient and his profession. And how do we measure the efficacy? Number of attacks per 6 months. And every patient, these patients send me an email now every 3 months, should give you feedback every 3 to 6 months by email or WhatsApp, and you adjust the medication. Personalized medicine. Medicina personalizada. Sí. Okay. Muchas gracias por la atención.